So this is the first webinar that I'm doing. So what we're going to talk about, and I guess really quick, I'll introduce myself. My name is Jessica. I am an ER nurse. I have been since 2007. And these are the kinds of things that I really wanted to go through today. But as I created this, I realized just how much information there is. So apparently this is going to be a huge series of multiple ones because this Zoom that I'm using is only 30 minutes long before it boots us off. So I'm going to talk kind of fast. Please just send a in the comments box if you have a question, and I'll try and answer those as we go. Okay. So what's a chief complaint? So the chief complaint that we talk about in the emergency room is the main reason why the patient came into the ER. They could have a million things wrong with them, but what did they come in for today? So one of the common complaints is chest pain. We also have complaints of shortness of breath. Abdominal pain is a very common complaint, and altered mental status, which could also be dizziness and fatigue to some extent. And then we have traumas or injuries, broken bones, car accidents. But like I said, as I created this, I realized just getting through chest pain and shortness of breath, I was already out of my 30-minute window. So we're just going to talk about those two right now. And this is really going to be like a 40,000-foot view of when a patient comes in complaining of these two things or one or the other, what we need to do as an emergency room nurse, the kinds of things we need to think about and get started with these patients. So let's talk about chest pain first. What organ do we worry about most with this complaint? Somebody comes in, they're clutching their chest, and they're like, oh my God, what's going on? So we worry about their heart. We worry about that they're going to be having a heart attack, right? It causes pain when you clog one of your arteries and the tissue on the distal side, so that's on the other side of the clot, starts to die because it's not getting oxygen. So it hurts, right? So if we have a patient that comes in, we're worried about their heart, what do we do to rule it in or to rule it out? Like, what is the quick and dirty we can find out right away without it being invasive? Right, so we're gonna do an EKG. So this is what a 12-lead EKG looks like. It lets us know about the electrical conductivity of the heart, and if there's an area that's damaged, then the EKG shows that. That's about as in-depth as I'm gonna go on EKGs, but just so you know, the EKG is what we wanna do. One of the other things that we do that are not, I don't know that they teach it in school or not, maybe they're up to par, but a troponin is a laboratory value that we want to get that is elevated. It's positive when the heart's having an acute issue and acute damage. So we want to get one of those troponin levels. So let's just say the EKG is fine. We drew the blood, troponin's off in the lab, it's cooking. We don't have that answer just yet. So, but we're not too worried because the EKG looked, you know, if you know anything about EKGs, that EKG looked really pretty. So we're not worried about that. What other organ system, if somebody's coming in and saying their chest hurts, what else are we worried about? Right, respiratory, we're worried about their lungs. So we're gonna look at them, okay? When we look at them, what are we looking for? We're gonna look at their work of breathing and their respiratory rate. So if they're huffing and puffing, gasping for air, their respiratory rate's through the roof, that's gonna indicate that maybe there's something going on with their lungs. And we're gonna listen, right? So we should all have our stethoscope with us when we're in the ER or anywhere really in a hospital setting. So we're gonna listen to them, and we're gonna listen for wheezes, rhonchi, rales, and in all honesty, those terms really aren't used in practice that much. Those are kind of nursing textbook terms, but people will be like, you know, they will say the word wheezy, but people will be like, they sound really coarse, or they sound rough, or they sound wet, or we'll talk about crackles. One of the huge things we worry about is if they have absent lung sounds. So that's kind of something we more worry about in a trauma patient. We worry that they have a collapsed lung or a pneumothorax, but we're not going to get into that too much today, or really at all. But just so you know, the sounds that we hear in the lungs are really going to give us an idea of what's going on in there. And then we're actually going to feel their chest, and it might sound a little bit weird, but one of the things we want to rule out is a reproducible pain. So reproducible pain means I can touch you and you feel it. I can reproduce the pain. I can't reproduce somebody having pain in their lungs or pain in their heart, but if I touch them and they say, ow, it's actually a good thing, because then they probably have a musculoskeletal problem going on. So maybe they, you know, exercised too hard the other day and their pecs hurt. They did too many sit-ups or too many push-ups anyway. Or they have a fractured rib from coughing so hard. You'll see that in elderly people. So we want to see if their pain is reproducible. But when we do that, the other thing that we're going to do or note is how their skin feels. So are they hot? Are they warm? Are they having some type of infectious process going on? So we learn a lot from these patients before we ever get their vital signs. So the look, listen, and feel is really the first thing you're going to do literally within 30 seconds of your patient coming in. So let's say everything's okay so far. Your troponin came back, it's negative, and the lungs are clear. Their respiratory rate, unlike mine right now as I fly through this, is normal. You're not worried about that. Nothing hurt when you touched them. Their skin felt perfectly fine. Can you think of something else that's super serious that could kill this person potentially? So we're worried about a pulmonary embolism. Okay, that's a super scary thing. For one, it's a hard thing to intervene on. Somebody's having a massive MI, I'll just send them to the cath lab, right? What do you do with a pulmonary embolism? Those can be pretty scary. And one of the things I'll tell you, so on the screen you see it says dyspnea, which is shortness of breath, unilateral chest pain. That's actually pretty common. So if it hurts on one side when they take a deep breath, that kind of sets off a little bit of a flag. Hypotension, in all honesty, unless it's super bad, the super huge PE, you may not see hypotension. One of the things that really we really worry about is if you've got a patient that comes in, is tachycardia. Okay, so if I have a patient that comes in and their EKG is fine, everything's perfectly fine, the thing that's going to go through my head is, like, if I'm getting a report from somebody, oh, you got a patient coming back from triage or complaining of chest pain, this, and this we did in triage are fine. I'm going to say, what's their heart rate? Because I'm going to worry about a PE. You could have somebody that comes in that seems totally fine. They say they feel short of breath. They don't necessarily look like it, but their heart rate's really high. It's like, well, why is that? So I'm going to start asking other questions. I'm going to start asking if they've had a history of a DVT, which is a blood clot in their leg, if they traveled somewhere, if they were in a car or in an airplane and they've been sitting for a very long period of time, if they have a history of AFib, or any other type of weird coagulopathy. People have these types of things that we're worried about. So I'm going to want to do a CAT scan of their chest. I'm going to do a D-dimer. So this is a blood test that is elevated when you've got some weird clotting process going on. It doesn't scream PE when that's positive. They could have a DVT. They could be pregnant. Sometimes in pregnancy, you'll have an elevated D-dimer. So it's not a surefire thing, but it's definitely something that really makes us go, wow, we really probably should do a CAT scan of this patient's chest, because they're tachycardic, they're complaining of chest pain, and now they've got an elevated D-dimer. So these are the kind of things that are quick and dirties to really kind of get to the problem before we ultimately have a diagnosis. So what else could it be? We've ruled out this person's not having a massive heart attack. They don't have a history of any type of weird clotting disorder or DVT or AFib or any of the things we just talked about. So what are other things that are going to go through our mind next? Pneumonia, for sure, is something that we're going to consider, but they didn't feel warm. So, they could have pneumonia without a fever. But some of the other things we consider when people are talking about chest pain, anxiety for sure. So I'm going to worry about acid reflux and anxiety and palpitations. These are really common things that are coming through with chest pain. So we worry about acid reflux, and then we also worry that somebody's just having anxiety. They can't catch their breath. They feel like their chest is tight. They feel palpitations. So these are two pretty common things when somebody comes in complaining of chest pain. So one of the things we do, not only to relieve the pain, but also to kind of help diagnose, is we give them something that's called a GI cocktail. It definitely doesn't look as good as what I have on the screen, but it is something that they drink, and it's a mixture of liquid lidocaine and Maalox, Some places, some ERs may add other things in there. A couple of years ago, I worked in an ER that we put Donitol in it. I don't know that anybody does that anymore because this medication has a lot of contraindications and side effects because it has atropine in it. So I don't know that we necessarily want to give Donitol to patients that might possibly still have something going on with their heart. All right, so benzodiazepines. These are anxiolytic drugs, okay? We get rid of anxiety with these. They're sedatives like Ativan and Valium. And Ativan's a pretty common drug that we'll give if we think that this patient may just be suffering from anxiety. So we're gonna move on to shortness of breath, okay? So with shortness of breath, somebody comes in, they don't necessarily have chest pain per se, but they're short of breath. What do we worry about? What organ do we worry about when we can't breathe? Somebody comes in and says we can't breathe. Right, we worry about their lungs. So we're back to our cute little lung picture. I'm worried that this person's having some issue, like the ones you guys talked about just previously, like a pneumonia maybe. But before I do that, one of the things that I really want to consider, okay, if somebody's coming in, is CHF. So how old is this patient? A lot of times, at least in the ER where I work, I get so many elderly, not even elderly, we have a pretty sick patient population. I get people in their 40s and 50s with congestive heart failure, okay? So I'm gonna consider their age, I'm gonna consider their cardiac history, and I'm gonna listen to their lungs. And if their lungs sound wet, I'm gonna worry that they possibly have congestive heart failure, an exacerbation of it anyway, and their history will kind of lead me to believe that, but also their wet lung sounds. And the reason their lungs are wet is because their pump's not working, their heart isn't working. So you're having this fluid backing up. So that's really the key, is how they sound. CHF is definitely a distinct sound when you're listening to lungs. So unless we have a young, otherwise healthy person that's, coming in, it's obviously asthma, or they've got a cough, it's an upper respiratory infection, they really don't have any other history, I'm gonna worry about their heart first. So one of the things that I wanna get is an EKG. Again, we're very EKG happy in the ER because it's super easy, it's super cheap, it's totally not invasive, and hey, why not? It takes 30 seconds and anybody can do it, a tech can do it, a nurse can do it. Anyway, I'm gonna rule out cardiac stuff as well. One of the things I forgot to actually put in this slide is a lab value for congestive heart failure is called a BNP, and I'm not gonna even try and pronounce it because I'll ruin it. I couldn't even say anxiolytic a minute ago. But it does measure the degree of the exacerbation of congestive heart failure. We're also going to want to get an x-ray. Okay, this is an x-ray of somebody that's having an exacerbation of their CHF. And that really also helps us to really get an idea of what's going on in there. So for the most part, when people come in, they're not really complaining of chest pain or of shortness of breath. A lot of times they're complaining of chest pain and shortness of breath. They pretty much go hand in hand, and a lot of the tests and a lot of things that we do are similar tests, right? So like I just said, somebody comes in with shortness of breath, I really want to rule out that nothing's going on with their heart. However, the first thing that we do, the second they come in, is their mental status. Because if we're worried about their heart or their lungs, we worry that they're not perfusing their brain. So if they're not perfusing their brain because their heart's not pumping oxygenated blood very well, or their lungs aren't oxygenating their blood very well, that's one of the first things that we really want to look at. But we're also going to listen to their heart sounds and their lung sounds. We're going to get an EKG. We're going to get their vital signs. We will order a chest x-ray sometime sooner rather than later. And again, we're going to draw labs, and we're going to want to check a troponin to check the heart, maybe a D-dimer if they kind of fall into that category that we're worried about a pulmonary embolism. And we may get a BNP if we think that there might be some congestive heart failure that's going on. So when we do this, like I said, this is the first thing we want to do. We want to make sure this person isn't actively dying right now, okay? They're not unconscious. They don't have muffled heart tones. They don't have absent lung sounds. And we're going to be asking these questions, obviously in order to assess somebody's mental status, not only are you going to ask them what's your name, what's your birth date, why are you here today, but you're going to ask them history to kind of see if they're confused or forgetful or if their brain's just not really working. But while you're asking these questions, you can do these other things. So generally you'll have somebody else in the room with you, unless it's super busy, then you are kind of stuck on your own. But you can ask these questions while you're doing other things. And that's really what we do in nursing. It's 500 things going on at the same time. And some of the other questions you really want to know, the what, when, why, is, well, what's going on? I'm having chest pain. Well, when did it start? It started this morning. Well, what were you doing when this? Well, I went for a run. Oh, I was mowing the lawn. And then is there anything that you've done to make it better or make it worse? Well, yeah, I stopped mowing the lawn and I sat down and it got better. Okay, we really are worried about an MI and somebody like that. But sometimes they've actually taken a whole bunch of medication. So you really want to know, oh, I took half a bottle of ibuprofen and it went away. Well, now we're worried about a GI issue too. So these are the kinds of things you need to do. However, at any point something seems abnormal, you need to intervene, right? You have to take care of your patient before you start, oh, but I didn't get their vital signs yet. Well, okay, but they're unconscious, start CPR. So what do I mean by intervene, right? Their mental status, they're unconscious. Well, okay, we'll get an check. Maybe they're a diabetic, maybe they overdosed on their insulin, who knows? And that's an easy fix, but maybe they need to be intubated. So we really need to look at their mental status. We do a Glasgow coma scale to do that. And there's this thing that we say, if it's less than 8, 15 is normal. If it's less than 8, intubate, but not so fast. Like I said, we're gonna get an check. And I realize I'm kind of going through this fast. I got 10 more minutes to go. But we're going to get an check, okay? And if their blood glucose is fine, then we are worried about it. But if it's 30, we're going to give them some glucose and get them back, hopefully. So we're going to worry about their heart tones. Muffled heart tones are bad. This means there's fluid in the pericardial sac. And if we hear that, we're definitely going to notify the physician. This is an emergency situation that needs to be addressed before we move on to anything else. Additionally, with absent breath sounds, we are worried about a pneumothorax, which actually can be a spontaneous thing that happens to young people. Generally, it's young, tall males. Don't know why. But if you have a young, tall male coming in saying, I can't breathe, definitely immediately listen to their lungs. And if you've got absent breath sounds, you may have to put in a chest tube in this guy. So diagnostics. You've got your EKG that you're going to do when a patient comes in. This one doesn't look like the other one, does it? Does anybody know what this EKG is showing right now? This is a STEMI, okay? This is an ST elevation MI. This person is actively having a heart attack. You see an EKG like this, yes, your face is going to look like that. So again, we're going to call the doctor and have him take a look at the EKG, and this patient likely is going to be going to the cath lab. So, what other, if they're not going to go to the cath lab and that's not a STEMI, what other acutely abnormal rhythms are there? Well, there's a lot. You could have BTAC, you could have VFib, you can have AFib with RVR, you can have SVT, tons of different emergency rhythms. Those will take you through an ACLS protocol, which we're not going to go through. Then we're going to look at their vital signs. And yes, you actually, with somebody that's coming in with chest pain, I get an EKG before I even get their vital signs. However, like I said, it's team, okay? We have a team in the ER. It is a multiplayer sport. And you're going to have somebody getting your vital signs and your EKG at the same time. So this is going to be a pretty hairy screen that I'm going to go through, but these are the vital signs. These are the things that could be wrong that you'll get from getting your vital signs. So you're going to have low blood pressure, possibly high blood pressure, tachycardia, which is a high heart rate, bradycardia, the heart rate's really low, tachypnea is them breathing really fast. They could have respiratory depression, they're breathing really slow. Are they hypoxic? Is their SpO2 really low? Do they have a fever? Or maybe they're hypothermic. We're going into winter now, and it's very possible that somebody drank a little bit too much and passed out outside, and their temperature's like 94 Fahrenheit. So these are the type of things that we're going to do based on what our vital signs show. And again, I'm kind of flipping through this a little bit fast, but as you see, I have nothing IV, MD, because it really depends. I mean, yes, textbook, if somebody comes in and their heart rate's 45, it's like, oh my gosh, their heart rate's so low. That actually might be normal for them. So we may actually do nothing. If somebody comes in and 110 is considered tachycardic, are we going to do anything? They might just have a little bit of anxiety. They just walked in. We're going to monitor them. If there's no other, reason that we think something's going on. Of course, if their heart rate's like 200, we're going to intervene. Maybe they're, having an episode of SVT. So there are a lot of things here that, like I said, this is how we intervene. If any of these things are going on with our patients, we're going to have to intervene before we even move on to anything else. So you put a pulse ox on your patient before you get their heart rate, before you get their blood pressure, and you notice that their, pulse ox is 85%, you're going to put oxygen on them before you ever even get their blood pressure. So this is what I really mean, is that you have to intervene when something's abnormal, and then you move on. So a chest x-ray is something that we're all going to get. I realized after I put this in here, they're all looking at a chest or an x-ray of teeth. But whatever, I didn't have time to put a chest x-ray. And so here you've got a bunch of nurses that don't really know how to read an x-ray, looking at this x-ray. What you really need to do is you order the x-ray. It's not up to you to read the x-ray. And even if you can read the x-ray, there's nothing you're going to do until a radiologist or the ER doc reads that x-ray. So we're going to get a troponin and a D-dimer. And the thing, like I said a little bit earlier, was that, unless that it really depends on how the patient's presenting, clutching their chest, oh my gosh, I'm, having a heart attack, their EKG is questionable, and then their troponin's elevated, we're worried about that. But if they come in with shortness of breath and no chest pain, and their troponin's a little bit elevated, but their EKG looks like it's kind of okay, we may wait and get another troponin, and then we look at trends with things that aren't completely straightforward. And the same with a D-dimer. But it's pretty much a solid shoot that if somebody comes in with shortness of breath and an elevated D-dimer, they're going to get a CAT scan of their chest. So let's go through some cases. I know I kind of blew through this guy really fast, but I wanted to get to these cases. I know that you guys enjoy them. So here's this guy. It's a 43-year-old male, and he comes into triage with complaints of chest pain and shortness of breath that started yesterday. He's got a history of type 2 diabetes. You notice that he is overweight. He's not a super healthy looking guy. This guy's not too overweight in the picture, but he says that his pain right now as he's sitting there with you is a 6 out of 10, but if he gets up and he exerts himself at all, it shoots up to a 10, and he feels like he can barely breathe because his chest feels like it's being crushed. You have a tech with you in the room, so you both can start doing things. What are you going to do first? Yes. Yeah. EKG and vital signs for sure, okay? So this is you. You're gonna look, listen, and feel like we talked about, right? So the person's pale, diaphoretic, grabbing his chest. You listen and his heart and lungs actually sound like they're within normal limits. Nothing sounds too crazy in there. But he's got cool, clammy skin, okay? And then while you're doing this assessment, you've got your tech getting your EKG and vital signs. So you get the EKG and you've got ST elevation and multiple leads, like the EKG I just last showed you. And these are your vital signs. So what are we worried about? What's going on with this guy? Right, we're worried about him having a STEMI. So now what are we going to do? This is the thing. You got this information. You need to intervene, okay? But you're going to start 2 large bore IVs. You're going to draw labs, specifically a troponin. You're going to place oxygen, like I said, based on your facility protocol. And if he hasn't taken aspirin at home, you're going to give him 4 baby chewable aspirins, okay? Morphine, depending, some we give morphine to. It depends on how bad the chest pain is. And per your facility protocol, we're going to start a heparin infusion and get this guy, ready to go. You've got your tech. So he's going to take that EKG that you just did, run it over to the physician and be like, hey, we got this guy. Whatever your practices are, whether the tech can call overhead for cardiac alert, but they can initiate that by getting whoever in place to do it. Put the patient on continuous monitoring. And then some places actually have point of care testing where they can run a troponin right then and there at the bedside. but they may need to take the blood off to the lab. So these are the kinds of things a tech or even another RN would be doing, because it's teamwork, right? So you've got this guy. What's the definitive treatment plan? Like, what is the ultimate thing we're going to do with this patient? Where does he need to go? Yeah, he needs to go to the cath lab. And so if you're working in a place that has that capacity, he's going to go to the cath lab. There actually are places that don't have a cath lab and can't get this guy to the cath lab fast enough. So there actually are some places that will give this patient TPA. And I know we hear about TPA with strokes, but I've actually given TPA to a person having a massive heart attack. Believe it or not, I have been in the ER with multiple people having STEMIs at the same time, and the cath lab's full. So what do you do? Like, and our backup really is TPA. So let's just talk about this last case. We've got an 83-year-old female. She's brought in by her caregiver. She's complaining of shortness of breath, cough, weakness. It's gotten worse over the last few days. She's got, you know, a whole grocery list of issues here, which is typical of an 83-year-old, right? And you've got a tech in the room with you. So, you know, her history is long and I've got it there. It's kind of irrelevant except for the fact that she's just not a super healthy person and she's old. So what do you want to do with her outside of the fact that she looks really uncomfortable and you want to get her in bed? You want to check her lungs. You want to listen, right? So here we go. We've got you and you're going to look, listen, and feel again, okay? She's pale, she's shivering, her lungs sound coarse, you know, it's like in there going around, maybe not that high pitched, I can't do it low enough, my voice won't work that way. And they're a little bit diminished. So, and you're gonna also feel that her skin is hot and very dry. So your tech, again, EKG and vital signs. These are the first things we're doing. You're assessing the patient, your tech's helping you out, getting things going. Her EKG, it's not going to be perfect because of her cardiac history, but it doesn't look like anything acutely wrong is going on. But these are her vital signs. They really suck, right? She's tachycardic. She's super febrile. Look at her oxygen level, 85%. Her blood pressure, you're concerned this lady's going to tank, right? Yeah, you guys are totally right. So we're worried about pneumonia. We're worried about the hypotension. We're really worried about sepsis with this patient. So what are we going to do? IV placement, yeah. So this is what you're going to do, right? You're going to put your patient on oxygen right away. Maybe your tech will, whatever. Somebody's going to put this person on oxygen right away, and we're going to assess her mental status. We're concerned that she's not oxygenating her brain, right? So we're going to start an IV. We're going to give her fluids. This person definitely is going to need a second IV, but at least get one in. Let's get some fluids going. Let's bring her blood pressure up. We're going to get labs, specifically lactic acid and blood cultures, okay, on somebody that we're worried about sepsis. Going to give her Tylenol. She didn't take any at home. We really want to get that fever down. She definitely needs a chest x-ray, which somebody had just mentioned, and her antibiotics to shortly follow. Always get your blood cultures before you start antibiotics. You'll get in big trouble if you don't. So we're going to be placing this patient on continuous monitoring too. We're really worried about her blood pressure. And we're going to initiate sepsis alert. So these are kinds of things that your tech can do, run around crazy. AccuCheck based on the Glasgow Coma Scale. So we're going to get an AccuCheck and make sure her blood glucose isn't just super low. And we're definitely going to get an EKG. So again, you guys kind of already mentioned it, but what do we think is going on with this person? Where do you think her infection is? UTI for, well, that's, I'm more worried about pneumonia based on what her lungs sound like, but absolutely so often, she probably has a UTI anyway. It's probably not what's causing this huge problem, but older women just constantly have UTIs. And if you have an older lady coming in complaining of altered mental status and seems like she may be having a stroke, she might just have a UTI and it's a very easy fix. So yeah, UTIs can just wreak havoc and cause a ton of problems in the older people, especially women. But this patient, I'm really worried about a pneumonia, and that's why I want to get a chest x-ray. That's why, you know, her O2 sat's low. Generally, you know, with a low O2 sat, you know, not so worried about a UTI, but definitely somebody like this has got an active infection. I'm going to get a urine specimen on her. So anyway, I realized I went through this super fast. I do want you guys to join my Facebook group if you haven't already. I've got a lot of questions or a lot of case studies on there. I'm going to keep creating free education. Hopefully, I'll get better at it. So sign up on my website, put your email in, and you'll be the first to know about the new things that I'm doing.